That's me. We can go to the next one. Let's see. Should I do that or you do that? Yeah, you do that. Oh, back one. Okay. So we've heard a little bit about how many. Okay. Let's see if I can.
This way.
Got it. All right. So we've heard a little bit about how many people we think there are in Oregon with hepatitis. So the hard and fast number is that we started hepatitis C laboratory reporting in 2005. And since that time, as of a week ago, 70,000 cases have been reported to us. So that's like, so every year I update this. It's like, oh, because there's 40,000, that's the size of such and such town. So now the idea is like, wow, so about somewhere between the size of Springfield and Medford is the number of people in Oregon living with hepatitis C based on positive lab reports. That's probably, of course, an underestimate because one, you have to have been tested. It has to have been after 2005. It has to have happened in this state or it wouldn't have been reported to us. In the last spring, CDC has done kind of some modeling studies based on the National Seroprevalence Study, and they've come up with an estimate for us of 90,000, and that's 3% of our population. I think usually you're used to hearing numbers of 1 to 2% of the population. We're 3%, and that puts us third in the country behind Oklahoma and the District of Columbia. On the other hand, we always hear, again, when they've done studies where they've done like a blinded study where they draw blood from a sample of people and come up with the prevalence and then go back and interview them, half the ones that had hepatitis C didn't know they had it. So there's probably, there's still more. I'm sure there's probably over 100,000. I mean, I don't think that we're going to, if you think, oh, well, 70,000 have been tested and there are 90,000 people, we just need to test 20,000 more. It's like, we get 5,000 or 6,000 positive reports a year. I don't think it's going to slow down in the next 5 years. Let's see, where do I need to aim this to make it advance? Can someone advance it for me? Oh, at you, okay. I think can you advance it for me?
Doesn't like it.
No. All right, thanks. This is just the map. So this is average rates from the period of 5-year period from 2011 to 2015, kind of showing where these cases are. Now, some of them are sort of boosted by the fact that if you're tested in a prison, it's going to be reported as the county where the prison is located, not where you are a resident. So some of, can we go, did I do something? Can we go back to the map? So some of these, not necessarily as high, but I think you kind of get the sense there's a lot in all parts of the state. It's not, I mean, usually people think, I think probably before we started publishing these maps, it's like, oh, that's kind of like a big city problem. That's a Portland thing. It's like, no, it's really, I tell people, it touches every corner of our state. So this is looking at our acute cases, and what that means to an epidemiologist. This is someone who's gotten it recently in the last 6 months. And basically the trends here are that you can see it's usually young people that are getting it. And I can tell you that 2/3 of these individuals have reported injection drug use. So this is skipping up faster than I wanted. Gotten it through injection drug use. So people acquire it pretty quickly. You can see the leading group there are people in their 20s and 30s. And overall, it's split evenly between men and women, although you can see in, what's interesting is in the younger age group, that 0 to 19, you had a lot more females. And then kind of in the older age groups, it tends to be more male. These are the risk factors, as I mentioned. Among people that we were able to interview and identify a risk factor, the majority have injection drug use as the most likely risk factor. We do have some healthcare exposures, and then the other risks are things like illicit drugs, not necessarily. I didn't do that. Okay, go back one. Maybe I should just put that down. And I can't be trusted. A little trigger happy, I guess. They report things like tattoos, piercing, contact with a case, or maybe some other blood exposure. But, as we commonly know, injection drug use is the most common risk factor for acute cases in Oregon. And next. And these are some national numbers from CDC, from all states reporting in. And basically what we're seeing is that among people under age 30, the rates of hepatitis C are going up dramatically. And I think as we've seen here in Oregon, the bright green bars, oh, see, that was not me. The bright green bars are non-urban, so it's either rural or suburban populations. It's rising the fastest there, and then the purple bar is urban. So it's really an issue. And again, it's predominantly among people who report injection drug use. Okay, next. And what we've seen here in Oregon, because it's so hard, it's really hard to find the new cases. I mean, our numbers, they really don't seem to be going up over time. We get about 20, 25 a year, and given the fact that a lot of people don't get reported, or a lot of people just don't seek medical care because 80% are asymptomatic, we think that 25 people is probably more like 300 people. One thing that we can sort of track, though, is that our chronic reporting, it's basically, it's lab reporting. So, and the counties, we can't even ask them to follow up on all these cases to really find out details and get a history of how they may have acquired it, because there's 5,000 or 6,000 a year. That's the number of all of our other reportable diseases, you know, our reportable infections added together. And so, let's see, yeah, back. So we don't know that much about them, but what's interesting is if you look at the age, let's see, we need to go back, I think, 2 slides. Oh, a couple slides. So one more, back to the year 2006. So kind of after 1 year of reporting, you see that you know, the vast majority of the patients who are just reported with presumably chronic infection, because they don't have symptoms and they haven't been reported as acute case, you know, they're between the ages, you know, in 2005 they were all between the ages of 45 to 60, and then the people in blue are people under the age of 35. But we assume that those are the people that probably have gotten it the most recently, because that's where we know that if you are injecting and you start, you know, in your teens or 20s, you're probably going to get it pretty quickly. So let's advance up 10 years to the next slide. And you see it's not horribly dramatic, but you can see that it's now what we call a bimodal distribution, where there's kind of like 2 age groups that are affected most. And basically, the older age group has just gotten 10 years older. Now it's kind of like 55 through close to, you know, 65 to 70, where most of the people are. But there's a growing segment under age 35. Okay, next. And then the other things we're looking at, and I have to thank, I think Jeff Capizzi is in the back of the room. I forgot to do an acknowledgement slide, but he's an HIV epidemiologist who's been very helpful about helping us out. And so he's done a lot of work looking at hospital discharge data. And so, you know, we don't have the capacity to go through and interview charts and really drill down and look what's going on, but using diagnostic codes, you can get things like, there is a discharge diagnosis for use and dependence on opiates, cocaine, amphetamines, sedatives, and other drugs. So first he selects those patients, those hospitalizations out. Now you don't know whether they're taking an oral medication or using, you know, injecting. But so then he further, you know, made the requirement, looked at people who had an infection that we think is probably related to injection drug use, like a bloodstream infection, a skin or soft tissue infection, and came up with these numbers. And so still, this is a big underestimate of people who are injecting, because you'd only get into this little pot of patients if you had one of these infections. So it's a good marker of like infections related to injection drug use. It's probably the best way. And the main thing to know is, even though this is not perfect, because we don't know a lot about these patients, that in less than a 10-year period, they went from 975 visits to 5,256. And I never tried to put myself in doing math in front of people, but that's an easy calculation. It's more than 5 times. Next. So if you look at it, this is interesting, because this shows, again, it's those same people, the 500 in 2008 and the 1,000 in 2008 and the 5,000 in 2015. It shows kind of what classes of drugs they were using. And to anyone who works with these patients, you know that it's not surprisingly, purple is the opiate line, and then black is amphetamines. And then the next one, this breaks it down by the infection type. So the blue bar is bacteremia or sepsis, so that's an infection in your bloodstream, pretty serious. The purple bar is skin and soft tissue infection. So a lot of people go into the ED, but these are people who are like sick enough to be admitted. And then the green one is endocarditis, which is an infection. That's like when you have, it starts out as a bloodstream infection, but then the bacteria lodge in your heart valves. And that's a big deal because you need like 6 weeks of antibiotics. So that's going to be a long time in the hospital or coming back and getting IV infusions of antibiotics. And then the last one, the yellow, is osteomyelitis. So that's a bone infection. So again, it gets in your blood, infects a bone, and that's going to be a big, that's going to be a long, expensive hospitalization. And so you can kind of see how that breaks down. Next. So this is kind of a thing that we've been showing for a couple years now, where, wow, our hepatitis C deaths are twice the national average, and they're about 6 times our HIV deaths. So it's, so HIV is a paradigm for what you can do when people can access treatment and you have good medications. What's interesting, so we knew that, like, yeah, this is bad. We're twice the national average. Let's see, go to the next slide. So this is, again, thanks to, we didn't know quite where we, like, well, how bad are the other states? Where else, who else has a lot of hepatitis C deaths? Well, they're all appropriately in black there, and we're among the top 4, and it turns out we're actually number 1. Yeah, not where we want to be a leader. This is a little bit more of a recent update. I think we topped out at 550 deaths in 2014. We've had some small declines. It's hard to know if that's going to be a trend or not, but we certainly hope it is meaningful. Unfortunately, the thing that we did notice in the profile is that we do have some marked racial disparities, and that's true of chronic infections, liver cancer cases, and deaths, where African Americans and American Indians, Alaska Natives, have about twice the rate of mortality as white Oregonians. And that has not changed in the last 2 years. Okay, next. This is actually some stuff that's on our injury programs website. I think some of you have probably been looking at this kind of data for a couple years, but again, it's kind of showing the marked change in just 15 years. So these are heroin overdose deaths, go back one there, and just seeing kind of how it's changed. I mean, if you just graph it on a line, it's a big steady progression, but I think it's always interesting to see where they are, and it's certainly most marked along the I-5 corridor, and you kind of can, if you can think back to our hepatitis C map, there's clearly a lot of overlap. And then next one. This is something that we haven't reported on before, and it's caught my interest because we knew that other states were starting to look more at perinatal transmission. In other words, transmission from mother to child, and we think that rate is about 6%. But just looking in our data, we have had very few infants reported, and so it seems like, well, I don't think it's a big deal here. And then, like completely by chance, I was at a meeting of this group of neonatologists and who were doing this initiative to reduce antibiotic use in NICUs, because that's another thing I work on is antibiotic use. So I gave my talk, and then I hung around for the free lunch, I admit it, and just chatting, because I'm a pediatrician, I just kind of chatting to people, oh, so what's your census like? What do you see in these days? And they're like, yeah, it's been slow except for the NAS. NAS is neonatal abstinence syndrome. And these were people, these were clinicians, I mean, this was like Kaiser Providence legacy, and they're saying, oh yeah, it's been slow, they're just people that are just hanging around, they're here for the NAS admissions, and like, oh yeah, half their moms have hepatitis C. It's like, whoa, we are not looking at this at all. So, luckily I had a student intern here last summer and had also found out that although it's not really published on our website, on a birth certificate, for instance, they capture a lot of information, demographic stuff about the mom, and for years they've always tracked like the mom's HIV status and Hep B. And it turns out since 2008, Oregon is one of several states that tracks that now. So we went and looked at it, and you can see, it's gone up a bit. Not dramatically. I think there's always this sense that, the clerk that writes this down is not actually speaking to the mom and getting a history. They're going through what's in the chart. So probably if the mom got tested during that pregnancy, which is good, it will be on there, but we know it's presumably an undercount. The other thing is because there is a lot of nice kind of information, we looked at some of the trends, and they're sort of not surprising. The risk of Hep C, it actually goes up with age because you know, the longer you are injecting or having that risk factor, you're more likely to have it. It's more common for a woman who has a live birth in that time period to be an American Indian, to have less than a high school education, have Medicaid insurance, to not have had prenatal care, and a history of alcohol and tobacco use. They don't capture injection drug use on the birth certificates, but you know, that wouldn't be surprising. So next slide. So we kind of knowing that it's underreported, it's like, well, how can we kind of maybe at least get a sense of you know, how many more are there? So what we did is we took the data from 2015, 40,000 live births, and then it's like, well, what's another way of looking to find out if people had Hep C? It's like, well, you know, we have a communicable disease registry, so at least going back, although we didn't make it reportable to 2005, a few people did get reported earlier, so we just took this whole group of women that had ever been reported with hepatitis C and did a cross-match. And it turns out that there were women who had been reported to us who gave birth in 2015 who didn't have this information on the birth certificate. So we increased that by, I think it was like a 60% increase. We added another 113 women to the new total of 294. So more than we thought. So close to 300 births a year. And then the next slide. Oh, and this is showing where they are. So again, it's kind of mapping out some of the stuff we already know, our risk factor corridors, I-5 and 84 there. And then the next one, it's very well established that what happens is the infant will have antibodies, but they could be the mom's antibodies, and so it takes a year and a half for those to break down. And so to really tell if an infant is infected, you have to wait till they're 18 months of age. So that's why we did the 2015. We looked, so that allowed us, because we were doing our study in 2017, okay, so now those kids, like even the ones born in December of 2015 will be a year and a half of age by summer of 2017. So there were 300 kids out there who were born to these women who should have been tested. Now, you don't expect 294 infants fortunately, to have hepatitis C because the transmission rate is 6%. So you expect 18 of those kids to be infected. And as of July 17, only 5 kids with hepatitis C who were born in 2015 were reported. So we think there's a lot of under-testing. Pediatricians are not aware of this topic. So this is something we need to work on in public health to find ways to promote testing and increase knowledge. And then one more, stay in my allotment. This is a new thing I'm working on, and part of it it's sort of progress report for a grant that you'll hear about next, but we're looking using hospital discharge data, and this is again pulled from the injury program. This is infants who are coded as having drug withdrawal syndrome. And we're hoping, I have another student working, and we're going to look at things like find out more about them, look at their length of stay, their charges, and stuff like that. And then we'll just go to my summary slide here. So I'm thinking the rest of the day is going to be a more positive experience. I'm like the lady who brings the bad news. But to sum it up, yeah, prevalence is among the highest in the nation. Our mortality is very high. We've got a lot of cases. The new cases are occurring in young adults. We know that our kind of hospitalizations related to injection drug use are going up. And then the new problem that we hadn't even worked on before and brings us new challenges are doing more to screen women and identify women who are delivering, whose children are exposed to hepatitis C. And then lastly, we'll try and do more to track neonatal withdrawal syndrome. Okay, oh, now I have to walk to the back. Thank you.